Tonight, I have the pleasure of introducing you to Associate Professor of Radiology from Yale University School of Medicine. He has a significant portion of his focus on pulmonary embolism and the treatment thereof. And he's going to give his talk today on the evolution of the treatment of PE from lysis through thrombectomy. Just as a reminder to everybody, if you have a question, put in the Q&A section. We'll go over all of them one by one at the end. And then we'll have a short little kind of blip as far as our final meeting, which will be in about 3 weeks, some of the details regarding that. So without further ado, Dr. Mojibian, I'm glad and happy for you to join us this evening, and the floor is yours.
Thank you so much. Thank you for kind invitation. Actually, when I saw the flyer, I was very happy because you put a picture of me from 15 years ago. I look very young. Also, I got very sad that how much I age at Yale, but it's very nice to be here. And then I'm just going to talk about our experience and the thing we learn and the way we do our PEs and how we see the change in the past few years. I have no disclosure. I'm just a local PI for clout study for NRE. And then we know that the PE is a significant cause of death in the world and the US. There are at least 100,000 deaths and probably closer to 300,000. And that was before COVID, related to PE and VTE in general, and now is probably that number is way, way higher. Mortality can reach 10 to 30% in 90 days. And one of the, if patients who survive, there are about 3.8% of those patients may develop CTEPH, chronic pulmonary hypertension, that is probably due to residual clot. And the PE, we know there's a #1 cause of the preventable death in the hospital setting. But not all the PEs are significant. All of us work in the ED and then work in the ED and then or read the CT and then know that how many incidental PE we can see or how many of these patients that they come with minimum symptoms. But the main thing is we have to remember that risk stratification for the PE is not based on the how much of clot you have, is mostly based on the RV function, right ventricular function, and also critical presentation. And the PE can be from asymptomatic to patient come with a massive PE and die in a few minutes. And the main thing is all the roads into the RV. You know, it's all about the RV that it causes the patient death. Is the increased RV afterload that causes start the sequela and the spiral of the death, and then it causes the RV dilation, then it causes the RV wall tension, and then inflammation, and then eventually the thing is, if nothing can get out of the RV, then nothing can come back to the left ventricle, and then if you notice, actually, that's the thing I'm noticing more and more, and there is one paper about it, that even in these CT images, you can see it to a limit that in the really bad PE, if you pay attention, you notice that your left atrium is completely collapsed because there is no blood come back to it. And then it's all about the RV-LV ratio. And there are multiple studies that show that when your RV-LV ratio goes above 0.9, they are associated with worse prognosis. And based on this, we have the risk stratification. Then this is a simple table that based on the European guideline that is becoming more popular, that we use it in everyday practice. And then if patient, we divide this patient to the high risk, intermediate risk, and low risk. The low risk have very low mortality rate, almost 1%. The intermediate is between 3 to 20% is very valuable. And then is all about the RVA gate. If patient comes with the shock or the hemodynamic instability, then this is automatically goes to high risk or massive PE. If patient comes with no RVA strain or no evidence of the ischemia, that means elevated troponin, then is automatically go to the low risk. If patient comes with the dilated RV, the sign of RV dysfunction, an imaging test, right? And then has then also has a positive cardiac biomarkers, that is mostly troponin, then they become intermediate high risk. But if there is only one of those, that means the patient have a RVS strain and no elevated biomarkers, they are intermediate low risk. I think this is a very important table that we have to remember. And also some people go with the modified PCS score or the PCS score, but that's the thing that most people are using nowadays. And then again, if the low risk, there is a 70% of patients are usually low risk, and there is no hemodynamic compromise, no RV dysfunction, no myocardial necrosis. Then massive or high risk, there are 5% of patients, and there are sustained systolic blood pressure. That means more than 15 minutes of less than 90, or the systolic blood pressure dropped 40 from whatever was before, and or patient needs inotropic support. And the mortality is close to 70% in this patient without treatment. And indication for treatment for PE beyond anticoagulation is we want to decrease the risk of the death, decrease the risk of long-term adverse sequelae, that means CTEPH, right? And also quality of the, improve the quality of their life. But who get the treatment? We know that the massive patients get the treatment with the anticoagulation plus latex. Then submassive patients, they are the patients that we are just mostly going to talk about. And then we know that the patients with the poor cardiopulmonary reserve or patient with the cardiopulmonary deterioration, anticoagulation probably don't have indication for additional treatment beyond anticoagulation. Patient with the intermediate high risk, and also the question is if even all the intermediate patients need to get treated or not. This is the algorithm that usually we use and most places they use. We assess the severity. If there is low inpatient, even now there is a lot of push for outpatient treatment of the PE. Then if there is a high risk, patient goes to ICU and intervention is needed. The intermediate, again, all of this patient with anticoagulation is floor versus ICU. And sometimes we do intervention based on the thing that we are going to talk about. Then the main thing is that when you want to do PE intervention, I said the mortality, it can be 3%, it can be 20%, right? We don't want to increase the complication of the treatment. That's a number one. That means we have to have a balance between the increased risk from treatment and just doing nothing. And the goal is that is a rapid relief of the PA obstruction, that it increases the pulmonary and systemic perfusion, and also take off the pressure from the RV, and it corrects the ventilation perfusion mismatch, and improve the oxygenation, and also improve the residual clot. Then we think that the probably historical VT treatment are not the answer, and they are not probably adequate. And the traditional and historical treatment is just anticoagulation. The anticoagulation conservative treatment has a complication happen with those. Then prevent efficiency of it is also under question, because we know that anticoagulation prevents additional clotting, but it does not really address the existing clot. And patients sometimes need to stay for a long period of the time in the hospital for that anticoagulation kick in and work. And there is also, at this time with all of this problem, most patients still only get treated with the anticoagulation alone. And then if you want to do a thrombolytic therapy, there is a significant risk with thrombolytic therapy. And if you look at I'm sure that you deal with this in your practice, that many of patients, for whatever reason, they are not candidate for analytic therapy because of the either absolute or relative contraindication to latex. And again, these patients, again, efficacy of the latex, if you want to, it takes time that they kick in, and it may at that time, many of these clots become resistant to thrombolytics, and also the monitoring of this patient, it costs a lot of money. But still, at this time, most places, the latex is the way to go for the treatment of this patient. And this reperfusion therapy there with, has been well studied relatively, and for the systemic use of the latex, there are multiple trials, PITO and MOPET. We don't get to those. And for the local, as a catheter-directed, is three major trials. There are Ultima, Seattle 1, 2, and Optilase. And Optilase is the one that is with the ECOS, and then it shortened the period of the therapy. And in that study, they used the RV-LV ratio as the surrogate for the treatment. And that's a problem with all of this trial, for the latex, for the anticoagulation, for everything, because we don't have much of the outcome. It's really difficult to evaluate the outcome except with the somehow a surrogate that is usually RV-LV ratio. And again, they measure the bleeding by the 72 hours. It shows that it decreased the RV-LV ratio, and then it was that's the reason that we really it kick in, and then it become popular. The Optilase really made the ECOS treatment popular. But despite all of this, there is no evidence. And then the last recommendation from CHEST does not recommend the catheter-directed therapy. The only thing they recommend is the systemic thrombolytic therapy for patients with the high risk or massive PE. And only if patient is not a candidate for systemic therapy, they may consider the catheter-directed therapy. Again, because there is no evidence to support any of these things that we do. But what other treatment options we have beyond systemic thrombolysis? We know that systemic thrombolysis cause bleeding, right? Then the other thing is catheter-directed therapy is pharmacological and mechanical. And what is the benefit of the mechanical? It's kind of, you can have an immediate symptom improvement. It can be single session treatment. It can eliminate the need for thrombolytics and ICU stay, and also it can minimize potential the blood loss and avoid need for capital equipment. And those are the nice thing about the mechanical, either with the catheter or even with the surgical. With surgical, again, patient has to go to ICU and have other complications, but this is the also option. And the thing that we have to also talk about it is the ECMO. That is really important to remember, and we briefly talk about it later. Then, and this is not, this evolution that is becoming like from the systemic thrombolysis to mechanical is not unique to pulmonary embolism. It happened almost in all other vascular care, right? If you know that, I don't know if you were in the med school in 80s or 90s or in the practice, right? Then giving the systemic thrombolysis was a big deal, right, for the treatment of the myocardial infarction. And then it moved to the mechanical treatment, that means the removal of the clot and the stenting. And the same thing with the stroke, right? We didn't have evidence for many, many years, but they repeated the studies. And then finally now the mechanical thrombectomy in the stroke compared to a systemic thrombolysis is preferred and is a treatment. And then also for the venous thromboembolism, we think that's the way we are going. That we are starting with the systemic thrombolysis, catheter-directed thrombolysis, and now we are going toward the mechanical. This is a slide I borrowed from NRE, but it doesn't mean that only our option is going to be the NRE catheter for mechanical thrombectomy. Then what is the problem with the transcatheter pulmonary embolectomy? What are the limitations? The clots are usually large. If you look at the right side, you can see this is just from last week that there was a patient with a PE and also clot in transit. And this is a clot that one of our cardiac surgeon took it out of the patient's right atrium. And the same size clot also he took out from the pulmonary artery. Imagine that the device wants to take this clot out, right? Then there's a large volume clot. There are coexistence of both organized thrombus and non-organized thrombus that make it potentially very difficult that you take the clot out if it's organized. Then the pulmonary emboli, there are multiple branches. It may be difficult to catheterize to take everything out. And this risk, as they get bigger, there are potentially more problem with them, right? If you put a big catheter in the artery, in the vein, sorry, then you have a chance of bleeding increases, you have a chance of thrombosis, then you have a chance of the injury to the blood vessels in the pulmonary artery. And again, you can, with all of the catheter manipulation, you may have a dysembolization, and blood with aspiration, you may have a blood loss. There are the limitation of the embolectomy. Is they're not that simple as they may sound. Then initially, I clearly remember that when I started, that's a thing we were doing not often, but patient was coming with the huge PE, with the massive PE in the shock. And then usually they were the patient end up in the cath lab and as a STEMI. And then they were doing the coronaries are not normal, but they noticed the pulmonary pressure is so high, and they were asking us to go and help. And then the only thing we could have done is take the catheter and then like the Picter catheter and then try to macerate it. A few times we use a kind of cleaner or Tortola device, and then we try to break those things. We didn't have much of the option. We just could have fragmented, let it go to more peripheral pulmonary vein, pulmonary arteries, and let it kind of a little bit help with the patient. Usually they were not that successful. I clearly remember one patient that I tried and was not that successful. Then, but the alternatives came to market and they become available. The alternatives or there are other that have been used in the other vascular territories, and people using it in the also pulmonary artery, kind of like the angiojet. And then, unfortunately, angiojet, there were reports of bradycardia, heart block, and many other problems, and there was a black label warning on the device, and the FDA didn't want to be used with the pulmonary artery, and it was not used. The Aspiration catheter is a rapidly rotating spiral with the negative pressure and causing maceration, aspiration. I have no experience with it. I don't think it's been used in the pulmonary artery that much. The other device that one of the earlier thromboembolectomy aspiration or suction devices that was available and become available, and we used it previously, was a penumbra indigo system that been used in the neuro intervention, and then there were the 8 French and now the 12 French that people use it in the pulmonary artery. There was a new trial just came out by our friend Dr. Sista, that extract P trial was a prospective multi-center single arm study. Again, they use the RV-LV ratio as a surrogate. There were 119 patients, and again, they showed that in 48 hours, there was significant mean RV-LV ratio reduction that potentially helped the patient. There were complications, but not significant. There's no cardiac injury. There was one patient that has a hemoptysis and then end up with the complication. And then I think there were 2 patients with the hemoptysis, one of them who unfortunately died as a consequence of multi-organ failure. But again, it shows that it's efficient and it can be helpful. And then also the ICU day, reduce the ICU day. But again, this device, my personal experience with it, that I just a few days ago, on Friday actually, the case came, with the renal vein thrombosis, and it did the magic. Amazingly, it clot the whole renal vein because the clots are smaller, right? But pulmonary artery, I think, is a little bit larger clot and may not be efficient. I have not used it to a French, but again, that may be changing the suction. But again, one of the things is the clot can be large and overwhelming for the device. Also, the blood loss, it could be a problem with this device. The other device is the AngioVac that was very exciting when it came out, and I think it has a huge potential to be used in the non-P pulmonary artery area, like in the right atrium. Even the right ventricle might be difficult because it doesn't turn. And imagine that it's such a big device. You want to take it to the pulmonary artery is really difficult. It's the 18 to 22 French suction cannula. You need the perfusionist and perfusions, and then some places they had set up the perfusion machine in the IR. We have not been able to do it. Then you have to do all the cases in the OR, either under the C-arm or if you have a hybrid room. And then also the fact that you need the support from perfusionists, it may delay everything. But it is really good for RA clot and also IVC clot. That is really nice. But there is a limited experience in the pulmonary artery with it. The other catheter that is from your city is from Dr. Bashir. I borrowed these slides from him. And then I have not used it, but I love to put my hand on it. It is, they noticed that when they were doing the coronary intervention, patient with the acute MI, with the thrombus, when they were putting the wire through the coronary arteries, they were noticed before even any intervention, the clot were resolving and getting kind of resolved by itself. And then they think is because of that there's an endogenous TPA or the latex in the blood products that you can really activate it, and that it may cause that resolve of the clot. And that's this concept that this catheter, it agitates the clot. Also, it at the same time, it spray the TPA. That means you have both effect of the endogenous and also external TPA, and it may help with the resolution of the clot. And the first publication with the human experience been really good. I think we have to see more study. The nice thing about this catheter that potentially can be nice is only 7 French, right? And it causes a prompt restoration of the blood flow. And then at the same time that you can monitor your PA through the catheter. And it's a low profile and it's easy to use, and there is no blood loss. We have to see really where it stands and if the trials shows that is efficacy and how it's going to work. There are other device now that is a big tiger or big lion in the room, and then elephant in the room, and then everybody is talking, many people are talking about it, and definitely we are been using it. And actually I wrote a paper about the detail of the device. Is a flow retrieval and is a large caliber aspiration catheter that initially was 16, 20, 22, and now there's a 24, and there is a straight and a curve format. And also the disc come with it. It can help to mobilize the clot if the aspiration alone is insufficient. The nice thing is that it really, the clot that does not respond to the thrombolytic may be pulled out with this. And then I think if you are using it, you get, particularly the first few times you use it, you're getting so excited about it because there is so much of the clot you come out of it that you never had such experience with it. And potentially can work for the both acute and chronic. The thing that we notice is this, that many of these PEs that we're taking out, may happen just yesterday, right? But it doesn't mean the clot is acute, right? It may clot be in the leg for days and weeks, right? And then they move and went to the lung. Because when you take this thing out Actually, they look like a very chronic looking clot, and then because they move from the leg that's been there for a long time. That means if you have acute PE, it does not mean you have an acute clot in the pulmonary artery. And then maybe difficult to answer it. And they have their own trial, and it's a FLAIR trial, and now they have a larger registry called the FLASH. The FLAIR trial, that data was published, is 106 patient, P within 14 days of symptoms. Again, they show that RV-LV ratio decreased, and again, it was significant reduction, but it still is above 0.9. And I think it's for the Indigo is the same thing. It don't go. I don't think any of these catheters show that you drop the RV-LV ratio right away to below 0.9. But again, the reduction is important, and so pressure drops, the pulmonary pressure. And that, interestingly, 40% of the patients did not need to go to ICU. I think in this COVID era is important. 3.8% of their patients had adverse event, 1 hemorrhage hemoptysis, and that 3 treatment clinical deterioration, but no intracardiac hemorrhage, no site bleed, and no related pulmonary injury. The catheters are big, and some people, they say, okay, is really afraid of you putting a 24 French catheter in the groin. We've been using it, and actually we presented in the SIR, and we use a PERT string technique, and we had one patient, we did probably around from 100 patients that we look at it, one patient was had the bleed 2 days afterward, and that was just stopped by holding pressure. And then the main thing I think is important, even yes, it decreased the RV-LV ratio, but we don't have outcome data, but it decreased the patient stay in the ICU. I think in this time can be really important. I just showed a few cases. This is a patient that came with the history of COVID infection about 2 months before. Then it came with the extensive non-occlusive thrombus, and also as a DVT. And then, as you can see, that's a typically we get. We had the large cavity size, then moderate to decreased function, and we had the right heart strain. And also, that was the thing that made us worry. Patient had the early right to left shunt after injection of the agitated saline, and they say it's an intracardiac shunt or from an wadi, and these are okay. Then the thing is this, that we publish again on this, that patient with the PFO and the thrombectomy is safe. We had one case in our data that patient got the stroke 3 days after our thrombectomy. But again, this patient had the large intracardiac, they were suspicious of the intracardiac shunt or the large PFO with the LD right to left shunt. And then I said, okay, this patient has a COVID, and then also maybe some more distal cause. And then we decided, when we had switched completely to mechanical thrombectomy, we used the TPA in this patient. And we use a TPA, and then only for 6 hours, patient symptoms got better, but in 48 hours, she got the huge intracardiac hemorrhage. And that was after months and months, that was the first TPA that we had used. Again, that was another patient that we had. Again, that's the thing, even in the young, relatively healthy patient, the bleeding may happen, and the bleeding is much more common than we think with the latex. Then there was another patient, our first thrombectomy patient was a patient, 75-year-old with the hernia repair, presented with severe shortness of breath. Then just had the hernia repair, just had the surgery, and had also prostate surgery a couple of weeks before, or a few weeks before that. Then we found that have a large PE and has a right heart strain. Troponin was elevated. The CT shows extensive pulmonary embolism, and the mild increased RV side. And he was father of one of our nurses, actually. And that was a CT. When we see the CT like this, then you see that this picture is, I'm very suspicious is the acute PE when I see this picture. The large PE was the RV LV ratio. And then we decided to use the first thrombectomy device on this patient. Then we can see the you have the feeding defect in the pulmonary artery, and you can see all the feeding defects. Then you can see a large feeding defect in the right, and these are from our PA angiogram. And then you can see the pressure was 42, and with a mean of 20. Then after did the thrombectomy, we were able to decrease the pressure to 28 with a mean of 12, and we got rid of the most of the clot. The heart rate is, quickly drop, and then O2 saturation elevated to 97%. Patient remain hemodynamically stable, and then TT show normal RV size after, I think, 48 hours. This was a clot we got. It's very amazing the first time you do these cases, that they are amazing, but it took us 3 hours or more, and then the first few cases it took us long, but then we reduce our procedure time. But usually you get the first case like this, but not all the cases going to be like this. Some cases are difficult. We had the case with the hemoptysis who unfortunately DC. But this mechanical thrombectomy, I think, also is very important in the patients with the large PE, massive PE. Like this patient was a 70-year-old female, and then who had to have a massive pulmonary embolism in the outside facility. Patient had the cardiac arrest, and in the CT scanner, patient was intubated, was giving the TPA, and then patient was on 2 pressor, and then even after TPA did not do much. They transferred the patient to us, and then troponin active were elevated. And then we decided we knew this patient is sick, has a massive PE, and now our algorithm is moving to those patients. Instead of thinking, okay, this patient may need the ECMO, we put the patient on ECMO first, and then we go with the thrombectomy, because we had the better result. Actually, if patient is a candidate for ECMO, put them on ECMO first rather than do it emergently. And this patient in the IR, we put the ECMO, and we did you can see it here. And the clot doesn't move. I just injected, give a puff and contrast, stay there, didn't go anywhere. And actually, we were able to do the suction thrombectomy. The clot is not big as the first patient I showed you, but again, it saved the patient. Patient stay intubated for about a week, but they were able to extubate her, and then did fine. There are all acute effect you see. Also, the other thing is important, either with the TPA or with the mechanical removal, we have to see how much of clot we leave behind, right? Then there are studies that shows with the TPA, you have better resolution of the peripheral clot, that it may affect the better outcome. Again, but also, I don't know how much TPA can get rid of the clot, and if it is a mechanical thrombectomy is more efficient, or the TPA, we don't know yet. But we know that patients, they have residual clot, they have a better prognosis. They have a worse prognosis in the future. Again, it just, this one also we keep in mind. The other thing we see, we don't know, like when we stop doing the removal of the clot, when you are going to stop. If you are going to, with the TPA, you put the patient on the catheter for 6 hours, for 12 hours, or whatever, and usually that's it. But with the catheter-directed thrombectomy, either with the Indigo or with the NRE or whatever device, what is the endpoint? How much of the pressure you want to drop? If your pressure doesn't drop, you're going to keep continuing this or not. And if you don't know exactly, we cannot differentiate between the fresh and chronic clot based on imaging that we have a guess that it may not work, or patient may need direct surgical thrombectomy. And for also the most important thing is this, that we don't have still we don't have an outcome, right? That they justify really, or not justify, we tell us which patient really needed and thrombectomy or TPA, or which patients really do fine with the anticoagulation except in the massive. And that's the place that the PERTing, P-responsive, come in action. I think is a consensus and a collaborative decision-making between all the players, and may help to make a decision. And usually that's the way that we've been acting on this. I think this is going to be probably the future. The thing is, we get the CTPA, then images go to PACS, radiologists review it, there's a radiology report, there's a clinician review, and then there's a PERT activation that go to page operator, and then everybody from ED, pulmonary cardiology, and the IR get together and then discuss what needs to be done. And it may take quite time, but it is very important that you have a discussion with the pulmonologist before you do any intervention, because at the end, they are the ones that are taking care of the patient. And then I just wanted to share this experience. It's very new for us. We developed a system with one of our industry partner that we've been using the AI algorithm for diagnosis of PE and for prioritizing the PE in the list. But since the COVID hit, then we also started having the alert system. That means every time that there is a PE and it goes to our AI alert system, and the AI thinks that this is a large enough PE with the RVS strain that it may need the intervention, it sends us the alert. The alert goes to interventional radiologists, to the cardiologists, pulmonologists, whoever want to be in that thing. And then you get the text. Now is come as a message, kind of we say, there is at the Yale New Haven Hospital, this period, there is a high possibility of the acute PE. And now we have an app that we can go and actually look at the images immediately. And then whoever is in the PERT team that is active at that moment, it can look at those those images, and then we can also look at the different plane. Because of the HIPAA, we're still not able to get the data, clinical data in this, but hopefully next stage. And potentially from here, you can initiate a Zoom meeting between all the PERT group to discuss if this patient need the intervention or not. I think, again, this we experienced that it significantly reduced our activation time, because we eliminated all of these steps. When we don't need the radiologist review, we as the interventionists, we review the images if the system thinks that the P is big enough to act. Again, having the group that have it, because there is not much of the evidence yet that which patient benefit from intervention, or then it's really important to have a discussion and the algorithm and the guideline to don't harm the patient and actually treat and give the treatment to the patient that really need it. In summary, there is no strong evidence for any interventional treatment beyond anticoagulation except in patients with catastrophic PE that may benefit from systemic thrombolysis, probably due to risk of bleeding offset the benefit value. And we think that the large bore mechanical thrombectomy is a promising new method without risk of bleeding, but we need data. We don't have a data. And then it's very difficult to really get the data and also have a kind of the head-to-head comparison between different devices, even between the intervention and the P with the outcome. Anyway, I'm here. I will be happy to answer any question if you have.
Thanks, Dr. Mojibian. I actually have a couple of questions as far as the PERT team. Does interventional cardiology play a role in that? Like I know with ours, we split the call. So it's like 2 weeks them, 2 weeks us. And I just didn't know, is it completely IR at your institution, or are they involved as well?
At our institution is completely IR. Is a pulmonary service. Let me correct myself. We have a health system. At the Yale New Haven Hospital, that are two flagship hospitals, that's SRC and the Yale New Haven York campus. Only interventional radiology provide the intervention. Cardiology tried it very briefly, but really did not pursue that. The vascular surgery wanted to get involved, that they have not, but is on the IR. But we have another hospital called Bridgeport, that at that hospital, there's a cardiologist been doing thrombolysis, and now we offer the thrombectomy, and now we start working together. Actually, we are putting also starting working there. That 95% of the health system done by IR. Cardiology, we always involve them for echo, because we prefer to get the official echo, and if possible with the bubble before intervention, but not always.
Okay, and then another question I had, I always feel like everybody's a little bit different with when they choose thrombectomy or thrombolysis. I think a few of us at Temple, if it's large left and right main, nothing kind of not, most of it's not extending into lobar stuff, or it's very minimally into lobar, we tend to lean towards Inari. If it's, or thrombectomy in general, if it's, kind of distal lobars into segments, we tend to go towards lytics, but I didn't know, I feel like everybody's a little bit different with how they kind of approach these. So I just was curious what your approach is.
Our approach is we brought the thrombectomy to the hospital. I think it was in 2000, just before a year before COVID, in 2019, in January, I think was. And then for 2.5 years, we did, initially we did some lysis, because some of the attendings were not, they want to spend hours, and because it was taking a long time for us, we didn't know what involved. Our system was not really well oiled then, but I can tell you for past probably 2 years, the only lysis case that we did was the one I showed you, that it bled. And we didn't do any other lysis. Then the thing is, we are very conservative on who we treat. We're not treating everybody. Then if patient has a bad segmental or subsegmental PE, that usually they are not that sick, or the RV is not that big, or they have a troponin. If patient doesn't have a troponin, we don't treat it. And then because of that, we've been using only thrombectomy. We completely switched to thrombectomy. Then at the same time, is interesting because many of patients that we were not treating before because of the contraindication, now we treat. That in 2.5 years, we are getting more than 100, we did more than 150 cases across 160 thrombectomies.
Wow, okay.
Dr. Mojibian, a question from Stephen Hunt here, Ben.
Sure.
Do you see though, like you said, so the mechanical thrombectomy is going to expand your indication kind of into those patients that were previously, high risk for getting pharmacologic lysis perhaps, but do you see an algorithm developing, maybe not at your institution, but overall in the field, where those patients who were able to tolerate lytics would get, the sort of standard 2 catheters up, get lytics, intraarterially, and those patients who couldn't would be more shunted towards or who had a higher clot burden would be shunted towards the mechanical thrombectomy, that you would end up in these kind of pathway algorithms where you could make that determination based upon, the underlying risk profile of the patient?
To be honest, like we are working on, the Yale is moving to a system called care signature. That means in the EPIC, everybody can bring guideline up about different things like the chronic venous insufficiency, heart failure, and then there are different groups that are developing different algorithm. I think Mayo Clinic had this thing, and we are copying it. We just finished our care signature algorithm for intermediate and high risk PE. And then it was the group we're working on, it was interventional radiologists, cardiologists, pulmonologists, nurse practitioner, pharmacists, and then we said that if is a we are strongly in favor of the thrombectomy every single time, except except that that hospital, our network cannot offer it. And then I might be biased, but I think again I think there are people moving as based on the other vascular territory experience, like the MI with the brain, that it moved from the thrombolysis, thrombolytics to the mechanical. I think this one also moved to the lytics in general, if patient get comfortable. But if the main thing with the lytics are they're easy for operator to put it in. It's not easy for nurses afterward, right? But easy for you and I, it takes me 20 minutes to put it on. But we are very biased. We think that, and again, that clot I show you that they took it out from the heart, I'm taking now with the RA thrombectomy, right? Is becoming our thing. That I personally think that mechanical is the future.
Because of the risks that come with using pharmacologic lysis. And so once you get over that hump, you're saying, of the comfort level and experience with the mechanical thrombectomy, there, once you get past that, then you're now in a lower risk category because you're not using systemic lysis. That's your argument.
Yeah, yes, systemic or catheter. Catheter-directed lysis almost has the same very high bleeding risk that people don't appreciate. I've seen it in my practice, a few of those, and they're really devastating. Then also, it's not just that, because many of these patients have a chronic clot. It's not as an acute PE with a chronic clot. I don't know how much actually lytics are going to work on the chronic clot, you know? And also you can see immediate result that patient feels better. And the other thing is that patient doesn't go to the ICU, right? And if the intermediate high risk, I don't send the patient to ICU after my procedure. I send them to a step down, and after a few hours, the groin is fine, they go on the regular flow, right? I think that's also for the cost saving is a huge thing. But it's not just the bleeding. And the other thing is this, that we don't have any evidence that really whatever we do for the intermediate group really helps, right? But you don't want to cause a problem. If you're not going to cause, you don't want to put the patient through a procedure that may cause a brain bleed, right? That's the reason I think the thrombectomy is going to be the dominant method for future.
The one question I had is, are there any, so have you ever had any issues, patient comes in, PE, filter in place? I've had a couple cases with FlowTriever where it's been difficult to deal with the filter. And I didn't know if there's anything specific that you do, if you've had any issues with it, or you know, do you, the one case I actually took the filter out because the system kept wanting to go central in the IVC, and it kept kind of literally ramming into it no matter what I wanted to do to it. So I just didn't know if you kind of run into those issues and how you dealt with them.
Yes, actually, I clearly remember a case that initially the patient came, initially they didn't want a thrombectomy, they asked us to put the filter. My colleague put the filter. The next day they said, no, we want it. Then I went there and I decided I took the filter out, do the procedure, put the filter back. But my colleagues, it again depends on the filter. And that I took it out because very fresh filter. One day I was afraid if I manipulate it, it's going to move, and I didn't want to go and take the filter out of the heart then. And but I think if you are, we had several cases that people went through the filter, but again, and the other thing is that usually I have not seen it personally that patient with that filter that had it chronically had a large PE that needed thrombectomy. Again, it depends on the filter. If it's the first filter, I would take it out. I would be very nervous to go with that 24 French because also we go with the 24 French now. I would, if not, you have to make sure your gore sheet, it goes through the filter and it parks above the filter. You don't want to go with the device through the filter. You definitely, the filter is a problem. And one of my, at the beginning, one of my colleagues tried with the 22 through the neck. Was not easy. It was not easy to do it through the procedure because patient had a bilateral DVT. We did through the neck was not easy.
Have you encountered any resistance just among the group, like some people wanting to participate because, as you said, the level of evidence is not there yet? Do you have some of the faculty at your place or some of the partners who just don't want to be involved, or is everybody just on board with it?
No, we are all on board with it. At the beginning, some of us did not feel comfortable to do this device, and they were doing the lysis, continue doing lysis. Then I remember one case clearly that I heard one of my colleagues that the case took about 4 hours. It was really long, and he was saying if I had doing that Optilase trial low a short thing, we were done with it now with the latex. But even those people, when they saw the result, and then when we streamline everything, they switch. And then the main thing is this, that we have a very, very strong relationship with our pulmonologists. We don't do anything, any procedure, except our critical care medicine say that it needs to be done. Actually, there have been several cases that we wanted to do, and because their group is huge, it's humongous. There are 100, I don't know how many of them are there, and these critical care medicine people. And one case I clearly remember from a few weeks ago, that we were ready to go, that critical care medicine say, no, I don't want it. It's okay if it's your call, and then we didn't do it, and patient got extremely sick, and almost we lost that patient, and we did the next day again, and then he went to the M&M. That's why we didn't do it. It's very important to have everybody in your group knows how to do it, and I think we did it at the beginning. Dr. Pollack, who is the senior attending there, and I got ourselves comfortable. We did a few cases together. Then we went in for every case until the people that didn't do it, they felt comfortable doing it. We didn't just left them alone to do it with the rep. Then we went there, and then because also you need to know, many of the younger people don't know how to cross the heart. That's not be easy. They don't know what views they need for proper pulmonary angiogram. They don't know if patient has a huge pulmonary hypertension, how to do a pulmonary angiogram. Some people may not know how to select the branches. All of these things, I think, they are learning process, and it's important that one or two in the group, they be comfortable to help the other people get to the speed. And also having a good rep is very, very important. We've been very lucky with our reps so far.
Are you doing many of these cases on call? Meaning, like, if I get a PERT call Thursday night when I'm on, for the most part, I'm usually doing them during the day. Like if I get a call like midnight or 1 a.m., we're usually not coming in the middle of the night for these. I'm just curious if you guys are.
We have a fellow, we hired him, and then poor guy is called from I think Sunday night until Monday morning, he did 3. Yes, we do in the middle of the night. And okay. The main thing is the thing is this, that our philosophy is we have to provide the service all the time, right? And to be honest, if you don't provide the service, somebody else will do. And that one case is enough. They tell you, okay, you didn't do this case in the middle of the night, when they may not do it ever, right? if they were the sole provider, if the cardiology, for example, was the sole provider of this service, they would leave the case for next day. But if you don't provide it, right, they come back and tell you, okay, you didn't do this case, right? And that's the reason we do it very often in the middle of the night even. And many of those patients kind of are more, again, we are very aggressive. We are not doing for the, we are very selective which patients need the intervention. Those most patients that we do it that are really cannot wait that long to go next day. We don't do it for any intermediate low risk patient. Every patient we do is intermediate high risk patient. Then we really want to do them sooner than later. And the other problem we have, if I want to do it next day, is going to be screw up the whole schedule. We have a full package schedule and it's impossible. Then we prefer to do it in the middle of the night or in the early morning. It's tough, but we do it.
Okay. I think
one last question about the other end of the spectrum, which would be the people who are in the massive. How are you guys dealing with those patients who really are, you know, crashing kind of situation?
Again, the massive patients, they are at this time, we know that the TPA is working and is indication, right? Then if patient come with the shock, right? Then they get the TPA. Actually, our guideline, exactly, we went through the guideline that how these patients get treated. If patient has a contraindication, then we are getting there to become more coordinated with our ECMO team, that they can come to the IR or start the ECMO there under imaging guidance. That actually we had very good experience. And then we do the procedure, but not every patient is ECMO. Particularly older patients don't do well for ECMO, and some patients older patients have a contraindication for ECMO, right? We done patients that they're really hypotensive on inotrope with it, but again, those patients is really important that you have your critical care medicine attending stay with you, again, because you cannot manage the patient and also do the procedure effectively at the same time. You need somebody else take care of all the other problem with the patient, and you just do the procedure. And even it happened that I asked one of my colleagues, for example, I remember clearly it was a patient, was a 30-year-old something patient on the OCP, and came with hypertension, but very agitated, very kind of confused. And then I knew that she's going to go down. And then I asked Dr. Pollack, and we scrubbed it, and in 45 minutes we were done. Again, it's important to be efficient and then have support. And then we hope that we get to the high-risk patient trial. I think we have not been able to get to that. Not able to, kind of, we're trying to get to that. There is a high-risk trial from NR is going to start soon.
It's good to hear. I think that we're all waiting to see in that patient population as well. So,
right.
But great lecture, and it's great hearing about your guys' experience, particularly the evolution over the last couple of years there.
Yeah, it's kind of, it was I can tell you that is everybody saw the how it works well, and then we switch. It's kind of now everybody, we really almost never do the TPA. Again, but we know that we know that our other hospitals, like in the network, that they do a TPA. We know for the fact, because now I have this AI machine, AI software, tell me about every P that happens, right? Even if I don't do the procedure, right? Because it reads all and it sends me alert. I know many of those patients don't get treated, right? Because they have a contraindication or whatever reason. Then I think it opens up the possibility of treatment to many other patients, many more patients. Also, I think the AI will help us that it democratized the P management, because now we are at the mercy, if we were at the mercy of our ED physician or the hospitalist or whatever to activate the PERT if there was a P. Now, as a pulmonologist and the interventionalist, we are in the charge, and we call them, okay, this is a patient with the PE, what do you want to do about it? And then many people didn't know about this. Okay, when there is an option, now we educate them and we tell them, okay, yes, the patient may have benefit from the thrombectomy.
Yeah, and I just think, just like with any GI bleed algorithm, we have a lot of these algorithms at all of our institutions that, you know, you gather a group of experts, including the pulmonologists and everybody, and you make these, you know, you make these algorithms based on whatever inputs we can possibly, you know, go over.
Right.
Do they have a contraindication, or what's their risk level for anticoagulation? What's the blood pressure? Do they have, just like you showed in that chart, which criteria do they meet? And like you said, you guys arrive at that high intermediate, you know, proposition and say, those are the only ones who really we're even going to consider.
Right.
But then the question becomes, so that everybody, the pulmonologist and you and the cardiologist and everybody can follow the same algorithm. Once you have it down to that level, then an AI very quickly can be automatically making those treatment decisions and shunting the patient towards the right treatment pathway. But until you have that kind of tree, you know.
Yeah. At this time, we are just diagnosing it. We just want to alert the physician about this, that they activate the algorithm, nothing else. It's just the only thing that this AI does, it detects large enough PEs, right? That is a PE is big enough, and there is a RV-LV ratio more than 0.9 on the CT, it activates the PERT, and then that's in the job of the ED, pulmonary, and the IR to decide, okay, this patient is indicated. The next step is going to be that they can decide. But at this time, we just want to know about it, to start a discussion. But before this, even we couldn't start the discussion, because if this clinician here didn't want to start a PERT, right? How do I know about it? Except my radiologist tell me there's a big PE. That many times they don't.
Right.
Okay. Well, thanks for the excellent talk this evening. Yeah, no, it's our pleasure. Just for everybody else, again, the next meeting is going to be June 15th. We'll send out some emails regarding the case presentation that'll happen on that day, as far as kind of how we'll go about doing that. That meeting will be a little bit different than our traditional ones over the past year, I guess. Try to have your cases in by June 1st to the Philly Pairs email address. But like I said, you'll get some emails regarding the details with that. And again, Dr. Mojibian, thank you again for joining us this evening, and hope everybody has a good night.
Please feel free to email me if you have any question. We'll be happy to help.